Hello, this is Dr. Neil Jackson. This talk is on cholesteatoma, otherwise known as a skin cyst of the ear, and this is an introduction for general audiences.
So the overall highlights of the talk are that cholesteatomas are destructive skin cysts of the ear. The problems that patients often have include hearing loss, ear infections that keep coming back, or that go away with antibiotics but then come back again. Cholesteatomas can grow and they can invade to deeper parts of the ear, including around the skull and even into the brain. The treatment for cholesteatomas is surgery. Often this is an outpatient procedure in which the patient goes home the same day. It is important that the patient understand that cholesteatomas can come back. In other words, they can grow back even after a otherwise successful appearing surgery. Therefore, long-term follow-up is necessary. I follow my patients for years if they've ever had a history of cholesteatoma. We'll talk about ways that we can follow a patient for potential regrowth. And because this can come back, it's important to understand that some patients do need multiple surgeries on their ear during their lifetime. This may be because the cholesteatoma has grown back, or it could be because we're trying to rebuild the hearing parts of the ear again. And really, the treatment is tailored to each patient's unique situation. So in this talk, which is rather lengthy, I have many examples of different types of cholesteatomas. So this advice is not for everyone who has a cholesteatoma, but I'm trying to include the most common examples. So I am Dr. Neil Jackson, as I mentioned. I'm a pediatric and adult neurotologist, otherwise known as an ear and skull-based surgeon. I have the ranking of associate professor in the departments of otolaryngology and neurosurgery. I am fellowship trained in neurotology. I'm also board certified in neurotology, and cholesteatomas are something that I see pretty much every day and that I operate on pretty much every week in my practice. So what I want to talk about today is just briefly talk about how the ear works, talk about what is a cholesteatoma, how we diagnose them, how we treat them, how we deal with the risk of them coming back, what's the patient's long-term outlook, and then I have some video examples at the end for those who want to see what the surgery would look like. One important disclaimer is that, of course, this is not medical advice to you as the individual. This is just for informational purposes only, and of course your situation would be unique to you, so you should get your own unique care from your doctor. The reason why I'm doing this is because hearing is this really incredible sense, and the ear is a pretty complex part of the body. It has lots of nerves that go through it, and it's got major blood vessels that go through the ear, and it's also right next to the brain. So cholesteatomas are these unique medical problems that can cause problems not just with hearing and with ear infections, but potentially they can be even life-threatening sometimes. There's also a lot of decision-making when it comes to cholesteatomas and how we manage them. There's decisions for surgeries, what type of surgeries. There's decisions of what do we do after we have a diagnosis. After we've done surgery, do we do a scan? Do we do more surgery? There's lots of decision-making that goes into this. So I'm trying to make my patients more educated so they can help make their own decisions. And as I've said many times before, all these tests and treatment options are very tailored to each individual patient. So it's important that the patient understands all the options before we make a decision. And finally, cholesteatoma, this is a challenging topic. Cholesteatoma it's kind of a hard word for a lot of people to say. So it's sometimes even harder to talk about. Many patients have told me that they've never heard of this before. It also has other names we talk about. So sometimes we call this a skin cyst, which doesn't sound too bad. Sometimes we call it a tumor, and it gets sort of misheard as cancer, but it's not a cancer. It will not spread to other parts of the body besides the ear and the surrounding areas. We often sometimes call it a growth. There's all these different names we have because cholesteatoma is kind of a strange word. It's also kind of not easy for us to diagnose up front always. It may require multiple attempts to diagnose it. The most common signs are ear infections that just keep coming back despite, ear tubes, despite antibiotics. And there can be a really broad range of severity. So for some people, they have a small cholesteatoma and they have like a one-time surgery and they go home and it's not a big deal. For other people, they could actually present with their brain abscess, and that's how we diagnose their cholesteatoma. As we say, oh yeah, you're in the hospital with a brain infection, and it's because you had this skin cyst in your ear. The treatment for cholesteatomas involves surgery, but we also use other medicines too. We use antibiotics, we use ear drops, and of course part of the management is not just a one-time surgery, but there's lots of long-term care. The management options, how we deal with these, it continues to evolve. So the way that we manage this, 30 or 40, 50 years ago is different than how we manage them now. We have new technologies, we have new techniques. And so the best thing 30 years ago may not still be the best thing today. So I think it's important that the patient understand their options. And again, the treatment really is tailored to each individual's unique situation. So this is the ear. So just to review some basic structures here of the ear. This is the external ear, otherwise known as the auricle. Then we have the ear canal. The eardrum is at the end of the ear canal. It's kind of partially cut away here so we can see the inside. This is where cholesteatomas kind of start, is right around the eardrum typically. Other structures to note are the malleus, the incus, and the stapes. These are the three bones of hearing. The three smallest bones in the body. They're directly underneath the eardrum. These are often involved with a cholesteatoma as well. The bone behind this area is called the mastoid bone. As you can see, it kind of has these little pockets, or we call it like a honeycomb of bone. And then much deeper inside all this is where the cochlea is. This is where the rest of the hearing happens. And these are where some of the semicircular balance canals are also located. I'm also going to point out that the space right above the ear is in the skull. That's where the brain is. So anytime we're talking about a severe cholesteatoma, there is a chance that it could involve the brain. There's also a major vein here. This is the jugular vein. It comes up through the neck right next to the ear. And so if there's a bad cholesteatoma, it can also affect flow through the jugular vein, which can be life-threatening. So for some patients, like I said, they just have a small eardrum defect. And for other patients, they have these life-threatening complications from cholesteatoma. So we'll talk about all these today. So again, we said all these cholesteatomas, we think they kind of start from the eardrum. So what is the eardrum? Just to review, it's this kind of small window membrane at the end of the ear canal. The two main purposes are to help us with our hearing. So it helps to collect and conduct the sound waves deeper into the ear. And also this is part of our protective layer of the outside of the body. So, our whole body pretty much is lined with skin, and the eardrum is no different. So this is the skin of the ear canal. And there actually is a very thin layer of skin as part of the eardrum. It's basically the outer layer of the eardrum is composed of skin. The problem is that sometimes that skin that should be on the outside can end up on the inside. And that is essentially what a cholesteatoma is. The skin that should be on the outside ends up on the inside, and it keeps growing. So that's why sometimes we refer to cholesteatoma as skin in the wrong place. So it's not abnormal tissue necessarily, it's skin, but as it grows deeper in, it becomes a different type of tissue. This would be an example of that normal skin of the eardrum that is sort of tucking in and growing in, and that is the problem. We're actually not exactly sure why this happens. There's different causes and some different theories. One is that basically a weak eardrum sort of collapses inwards, and that's how the cyst can develop. Also, if there was a hole in the eardrum, that's an opening that the skin can go through, or of course, for some people, they're actually born with it. A common story for people with cholesteatoma is many times they've had lifelong problems with the ear. They've had many infections in their lifetime, perhaps even multiple surgeries already. They may have drainage or leakage out of the ear, which could be bloody, in addition to being infected. And then often the patients will tell me that they've gotten some temporary relief from antibiotics, but then the infection comes back a few weeks later. And so I will often meet them after they've been on many, many rounds of antibiotics. The other thing to understand is that cholesteatomas can really vary. They can really be quite different from patient to patient. So we have different things we look at that we can judge them on, such as the size, the location, how much they've spread, and things like that. And so some of these can be more favorable. They can be better to have, and some can be unfavorable or kind of worse things to have. So in general, you'd rather have a small cholesteatoma that we say is intact, meaning it's still contained, that cyst has not ruptured. That would be an unfavorable thing. It's also usually better if they're pretty confined to just where they've started from. So if they're just around the eardrum, that's favorable. They can spread many other places outside the ear, which can be problematic. So yeah, limited spread is better and extensive spread is bad. Also hearing, sometimes a patient will actually have pretty much normal hearing with a cholesteatoma, which is a good sign. But many times they have some degree of conductive hearing loss, or in the worst case scenario, they can actually have a severe sensory neural hearing loss if the cholesteatoma eats into the inner ear. And then finally, some have infection and some don't. And also the patient experiences and outcomes can really vary quite a bit because, again, these are all such different cholesteatomas. So for some people, there's a different number of surgeries. Some people just need to have one surgery and they're done. Others need many more surgeries. Again, the hearing, some patients can go through all this experience and have normal hearing at the end. Some don't have normal hearing and either need to have either some sort of implant or perhaps some sort of hearing aid to help them hear better, or just learn to deal with hearing loss. Some patients require eardrum reconstruction. In fact, I would say most do, but sometimes we don't have to reconstruct the eardrum. But many patients do need a mastoidectomy, which is opening up the mastoid bone behind the ear. And finally, the extent of the mastoidectomy can vary. We'll talk about preserving the canal wall versus taking the canal wall down. This is an example of that. So again, this is an eardrum here. This is the first bone of hearing and the second bone of hearing. And this little blue spot we see, this is the weak spot in the eardrum. And this is how cholesteatomas can start. So they can start here, and then in the next phase, they can spread deeper in. And at this point, this cholesteatoma is now spreading and growing on top of the second bone of hearing, which is the incus bone. This is the bone that's most commonly involved. So sometimes when we do a surgery for cholesteatoma, to remove the cholesteatoma, we have to take out the incus bone because it's got cholesteatoma on it. And then beyond that, it can spread deeper into the mastoid bone, which is the bone sort of behind the ear. And that can be potentially very serious because if this were to continue to grow from the eardrum towards the mastoid, now we're talking about different areas that can be infected. So the brain is right above the ear. And so if this cholesteatoma spreads, it can potentially get close to the brain. Cholesteatomas are notorious for eating through bone. So for some patients who have a thin amount of bone right here, the cholesteatoma can eat through it. That can expose the patient to a brain infection. Same thing here, there's a major vein that eventually becomes the internal jugular vein, and it's called the sigmoid sinus when it passes through the ear. And so if this cholesteatoma spreads all the way to the sigmoid sinus, it can cause the blood to stop flowing in that very important vein, and that can be life-threatening as well. And finally, the facial nerve is this yellow nerve, partially seen here, kind of actually runs from the whole course of the ear. This facial nerve can also be affected by the cholesteatoma, such that a patient could have a facial paralysis or a facial weakness. So we talk about cholesteatomas with ear infections and hearing loss, but they can also sometimes cause very, very important vital functions to also be threatened. Okay, so how do we diagnose these serious cholesteatomas? Well, it starts with taking a really good look at the ear. In my clinic, I'll use usually a microscope as well as an endoscope to get the best view possible. Oftentimes, these are infected, and so the first thing we have to do is to clear the infection. I often will also order a hearing test to check for any type of hearing loss. That'll also kind of clue me in. And then finally, a scan. If I'm suspicious for a cholesteatoma, I usually will get a CT scan or a CAT scan. This is to check and see if there's any sort of abnormal tissue in the ear, and also to check for any bony destruction. If there is something, we'll often do an MRI scan. This will tell us more detail about the mass that we see. This will also tell us if there's infection, if there's any growth, and also how the brain's doing. So a normal eardrum, if you look at a picture of an eardrum, it would look something like this. So again, there's skin around it. All that skin looks healthy. The eardrum is this see-through membrane. And then we can often see the first bone of hearing, which is attached to the eardrum. And if you look closely, sort of looking through the membrane of the eardrum, sometimes we can start to see the second bone of hearing right here. When we look at abnormal eardrums, for example, this eardrum has a large hole in it. So this one, potentially, the skin of the ear canal and of the eardrum could potentially grow through this hole to get into the inside of the ear. Or more commonly, we think about ears like this, where there are different pockets of the eardrum where technically there's not a hole, but the eardrum is very weak and very retracted. And so we think this is where some of those skin cysts can begin to form from the ear essentially folding in on itself. So common spots are up here towards the top part of the eardrum, and also in the middle part, and then right around the bones of hearing. So these are pretty common images of eardrums that are at risk for cholesteatoma. Once we know there's a cholesteatoma, it looks kind of more like this. This is a much larger pocket, and there's actually some earwax filling in here. Here's another example of this where the white we see is the cholesteatoma, and there's been a buildup of earwax, maybe some dried skin that's built up around it. Here's a view of a cholesteatoma, actually of the ear canal. This white mass here, this is the cholesteatoma, right next to an eardrum. These are all right ears, and then I have some left ear examples. Again, this is an eardrum. We see there's this white mass right here. This is the cholesteatoma. It's essentially tucked in between the first bone of hearing and the second bone of hearing. And this all is a very weak part of the eardrum, totally collapsed down. This is another left ear in which most of the eardrum looks normal and looks great, but the top part is all fallen in and retracted. This is a large cholesteatoma as well. And then this is another eardrum that you can barely see anything in because it's been mostly destroyed by cholesteatoma. So there's one large hole here, another hole here, and there's all this white that we see on the inside. This is all a lot of cholesteatoma building up inside the ear. So those are some nice classic images, but oftentimes it is difficult for us to visualize this. Because the cholesteatoma by definition is inside and internal, sometimes it's hard for us to see it. Oftentimes there's also infection and swelling, and so that can sort of obscure or cover up the cholesteatoma. So that's why sometimes the cholesteatoma is actually not diagnosed on the first time you go see the doctor for this. It may actually require that we treat the infection, clear the infection, and then we can actually see the cholesteatoma. And sometimes we actually don't see it or discover it until during surgery, until we've actually gotten to go inside the ear and get a good look at it that way. Here is an example of a draining ear. This is the right ear. So if you just look at first, all we see is a lot of infection in the ear. And in a second, we're going to use a vacuum suction like this, so we can suck out all of this infection. Here is a view of the eardrum finally. So the patient does have an eardrum. But as you can see, there's a large defect up here, and we see this red tissue as well. That's a polyp, which is usually a sign that there is a cholesteatoma deeper inside. And of course, yes, this defect should not be here. This should all be nice and flat. This is the eardrum. This is the defect. This is a polyp, which is a sign of cholesteatoma. So we're not able to always see these things until we clean out the ear very well, either in the office or in the operating room.
Here's an example of a blood-filled polyp in the ear. What we see in this left ear is that the patient has been having bloody drainage for the last few weeks. And then when we look right in the middle part, we see that there is a large blood-filled polyp coming from the eardrum area. This patient has mostly just had bleeding for the last few weeks, and that's what prompted the visit to the doctor. So whenever we see these blood-filled polyps, we're very suspicious of cholesteatoma. We can note that we actually do not see any cholesteatoma as far as a white mass, but what we do see is this large polyp of the ear. And this is a very concerning or very suggestive of an underlying cholesteatoma. So these patients, if they present like this, will often get imaging to confirm that there is a cholesteatoma deeper inside.
We often will also use CT scans, as I mentioned earlier, to help us figure out what's going on. So usually in a CT scan, we're checking for bone and for spaces. So the bone should be white and spaces should be black. So for example, on this side of the patient, all we see is black and white, which is good. If you look closely on this side, however, there is some gray tissue inside the ear, and therefore we're suspicious of what this is. This is actually a cholesteatoma. We also can see that one subtle thing is that the bone is sort of eaten away here. If we compare it to the other side, there's this sharp point. This is a normal sharp point of bone that we look for. And on this ear, we see that that sharp point has been lost. So we know that this bone has been eroded or eaten away. So this is sort of a classic or a very common appearance of what a cholesteatoma would look like. Right by the eardrum, right by the bones of hearing. In all this gray space up here, this is the brain. So as you can see, these cholesteatomas are usually just a few millimeters away from the brain. Here's another view of a cholesteatoma. Here is a CT scan shown from a different angle. Again, we're hoping to see black and white. On this side, all we see is gray. That's not very specific, so sometimes we'll do an MRI scan, and the MRI scan that lights up as white here will tell us that there is cholesteatoma inside the ear. Okay, so what are the goals of treatment? Again, we want to remove it completely from wherever it is. If it's behind the eardrum, if it's in the mastoid bone, wherever it is, we have to go to remove it. We also want to rebuild any of the damaged structures. So typically this is the eardrum we're going to rebuild. We're also going to check the bones of hearing, the ossicles, and rebuild them if we need to. And then finally, again, there is this, we know there's a chance it could come back. So we know the patient may require multiple surgeries. They may even require like what's called a radical surgery or a pretty like final surgery for cholesteatoma. So again, we've talked about the different structures of the ear. And again, these cholesteatomas, they're going to usually start right around the eardrum and then either spread either to the bones of hearing, into the mastoid bone, or other places potentially. More specifically, what we're talking about is these different types of procedures on the ear. So there's a procedure called a tympanoplasty, which is the term we use to rebuild the eardrum. There's ossicular chain reconstruction. The ossicular chain or the ossicle chain, these are the little bones of hearing. And sometimes those get eroded, so we have to rebuild those at the same time. There's also a mastoidectomy. This is cleaning out the bone behind the ear, the mastoid bone. And then finally, a graft harvest, so obtaining that tissue from the body to help patch the eardrum where that weak spot or that hole was. And really the type and the extent of the surgery are really based on the type and extent of the cholesteatoma. So again, tympanoplasty, this is an eardrum reconstruction. This is usually if the ear cholesteatoma is just pretty limited. For example, if it's just underneath an intact eardrum, we can lift the eardrum, remove the cholesteatoma, put the eardrum back down, and that's it. But very often we have to do more than that, so the tympanoplasty is combined with the mastoid procedure. Eardrum reconstruction and mastoid surgery is a large part of cholesteatoma surgery. For a much more in-depth discussion, you can go either to my website or to my YouTube channel for a video entirely dedicated to eardrum and mastoid surgery. This goes into the nuances of the surgery, how we do it, what materials we use, and what the patient can expect afterwards. For the actual tympanoplasty portion, or the eardrum portion of the surgery, what we want to do is repair a defect. So sometimes with cholesteatoma, the eardrum either has a hole or has a weak spot that we want to repair. So what we do in the surgery is we use our small instruments inside the ear canal, and we will essentially make some cuts around the eardrum by cutting through the skin of the ear canal. And we'll do that using a variety of instruments. And what we want to do is liberate, free up, and then lift the skin and the eardrum all in one piece. And so we'll do that very gently by kind of pushing and prodding, and we'll lift the skin off of the bone. And as we do so, we will then be able to see underneath the eardrum into a space called the middle ear space. Here we see the first, second, and third bones of hearing. This is often where cholesteatomas will start from. This is a great place for us to start the surgery, to identify where the cholesteatoma is, how big it is, and where it's trying to spread. For the purposes of this slide, recall that we're going to try to repair this defect. So we'll take a graft or a patch and we'll slide it in at the end of the surgery, and then we'll unfold the skin that we raised earlier in the case. And what we want to do is either cover up the hole or at least strengthen the defective part of the eardrum to make it stronger. Another thing we'll talk about is ossicular chain reconstruction. So again, very commonly cholesteatoma will grow along those bones of hearing. It'll damage the bones of hearing, the ossicles, and so we want to rebuild those. We often will rebuild them with something artificial, like a prosthetic hearing bone. These are often made of things like metal or plastic or cement, and so they're very strong, they're very rugged, and they will not be eaten away by any future cholesteatoma growths. One simple way to conceptualize this is that if this is what a normal ear looks like with the first, second, and third bones of hearing, if there's a problem with that second bone, and for example it has to be removed, like in this situation where it's absent, we can simply place a prosthetic between the eardrum and the third bone of hearing, and this will help the hearing significantly. The timing of when we rebuild the bones of hearing can vary. In many cases in my practice, the reconstruction is done at the same time as we were taking out the cholesteatoma. So I try to do all this just in one big surgery. However, sometimes we will have to delay that reconstruction if the ear is like really inflamed, really infected. And some surgeons just do this every time. And this is called doing this in 2 stages or using a staged reconstruction. And that means that the first surgery, we just take out all the cholesteatoma, let the ear settle down, and then we come back anywhere from 3 to 4 to 6 months later after all that healing is complete, and then we rebuild the hearing part of the ear.
When it comes to mastoid surgery, there's many options that the patient should know about. One thing to review is that the mastoid bone is this fairly large bone around the ear canal. It is both above, behind, and below the ear canal. This is a view that most patients are used to seeing the mastoid bone in. This is another view that I think is more helpful for understanding the next section here. This is sort of like a sideways view, or what we call an axial view of the ear and the temporal bone. So this is a view of the ear canal. This is the eardrum and the bones of hearing inside of it. In all this space back here, this is all the mastoid bone back here behind the ear canal. So as we can see, it's sort of irregularly shaped and has these different honeycomb air cells within it. One important thing to really understand is this area highlighted in blue here that we call the ear canal wall. We'll talk in a second about how we can do different things with this wall during surgery, either leaving it intact, leaving it as it is, or sometimes removing it, and what that means for the patient. So technically there's different types of surgeries that we can do in the mastoid for cholesteatoma. The most common one we just refer to simply as mastoidectomy. This is basically removing some of the bone behind the ear to remove the growth of the cholesteatoma and really any infection around it. This can be done for a growth of any size. This is far and away the most common mastoid procedure that we do for cholesteatoma. There are 2 other procedures to talk about. One is a very limited procedure called an adichotomy or a mastoidotomy. This is removing just a small amount of bone that's right near the eardrum. And this is only used whenever there's just a very small growth right around the eardrum, just a little bit behind the bone. And finally, there's a final technique called the canal wall down or a radical mastoidectomy. This is removing essentially all of the bone near the eardrum and that bone that I showed you on the last slide that separates the ear canal from the mastoid space. This would then connect the ear canal to the mastoid space, making one very large shared space. And I have slides to discuss that. So in this rendition, I have the cholesteatoma seen here as a small gray transparent object here. And really the surgeon is trying to get through on the axis of his black arrow. So if some of the cholesteatoma goes behind this bone, this ear canal bone, we can sometimes do a limited removal of this bone called a mastoidotomy or an adichotomy that allows the surgeon to get to all of the cholesteatoma for removal. So again, a mastoidotomy, this is a pretty limited procedure, just done for removing a small amount of bone right near the eardrum. This is only for really small and medium-sized cholesteatomas, which in my practice are probably less than 10% of the cholesteatoma surgeries that I do. We often will want to reconstruct or rebuild that bony defect with a piece of cartilage at the end, and this may be done in addition to an eardrum repair tympanoplasty, as well as in addition to an osteocular chain reconstruction. The most common procedure that we do is a mastoidectomy. This, because there's other variations, we sometimes call this a canal wall up, because we're leaving this canal wall up and in position, or a canal wall intact, because we're not taking down this canal wall, which is the bony wall between the ear canal space and the mastoid space. So in this procedure, in a standard mastoidectomy, the surgeon also comes in from behind the ear. So there's an incision behind the ear. We can open up the entire extent of all the mastoid air cells that are seen here. Often the cholesteatomas will start near the eardrum. They will spread out towards the mastoid. So for us to get all the cholesteatoma out, we must go into the mastoid this way to remove it. So mastoidectomy is cleaning out the cholesteatoma and the infection from the honeycomb of bone behind the ear. This is commonly performed in probably over 70% of the cholesteatoma surgeries that I do. This is absolutely necessary for cholesteatomas that grow deeper. The benefit of this procedure is that it preserves the natural shape of the ear canal, and it also keeps the ear canal and the mastoid spaces separate. This is important for water getting in the ear later on, and also earwax that would want to leave the ear. The reason why I mentioned the canal wall up or the canal wall intact is that there's also a procedure called a canal wall down mastoidectomy, and this is really for more advanced cholesteatomas. What does that mean? Well, this is for patients who have already had at least one mastoid surgery and are still having cholesteatoma come back and cause problems. Sometimes patients have had a regular mastoidectomy 2, 3, 4, 5 times before we do a canal wall down procedure, and there's reasons for that. The canal wall down is also beneficial for patients who really should not be able to tolerate multiple surgeries. So this would be someone who's very old, someone who is very sick, and the most surgeries we can probably offer them is one due to other medical reasons. And so if we only have one shot at a surgery for cholesteatoma, we'll do a canal wall down because in theory, the patient should not need any additional surgeries after this one. We also use the canal wall down technique for cholesteatomas with severe ingrowth. So if the ear is really destroyed, basically beyond what we think we can repair back to normal, then we'll just convert it to a canal wall down mastoid cavity. Also, sometimes in some ears, it's either unsafe or unrealistic to remove all of the cholesteatoma and rebuild back to normal, and so we'll just convert the ear to this canal wall down mastoid. So what does that mean? So as I mentioned, this is the mastoid bone, and this is the ear canal space here, and normally the two are completely separate. In the canal wall down surgery, we remove this bone in addition to all of the mastoid bone, and therefore all this becomes one large space. Again, the ear canal wall bone is highlighted here in blue. We typically will leave this up or intact on a regular mastoid surgery, but if we're going to do a canal wall down, we'll want to take down or remove that part of bone as well. So what this means is that if you start with a normal ear like this, where there's ear canal, eardrum, and mastoid as 3 separate spaces, if you convert it to a canal wall down, then this looks much different. In fact, this is just one large space seen here. This patient has also had an eardrum reconstruction as well as osteocaudal reconstruction, which is pretty common when a patient also has to have a radical surgery. What you'll also notice is that there is a much larger opening to the ear canal. So the normal ear canal is maybe a few millimeters opening on this one. For patients like this, we have to open up the ear canal much larger in order for wax and other debris to be able to be removed. And also there's just a much larger open space in here. So this is going to be much easier for things like water and earwax and dead skin to build up over time. So the canal wall down for advanced cholesteatoma, it's a very good technique when used appropriately. We essentially remove or take down the canal wall. This will connect the ear canal and the mastoid bone space into one common space. And the benefit of this is that if the cholesteatoma tries to grow back in the mastoid, it is visible through this shared open space. That means the doctor can see it in the clinic and just remove it right there in the clinic, and we do not have to go back to the operating room to remove the cholesteatoma. So really, the benefit of this is that the patient would not have to have any more surgeries in the operating room for a cholesteatoma. Sounds pretty good. But there's pros and cons of the canal wall up versus the canal wall down. So with the normal mastoid procedure, which we do most of the time, the canal wall is kept intact and the surgeon just works around it. This preserves the natural shape of the ear canal and the eardrum, and so patients do much better with this. Long term, they're able to get wax to fall out of the ear. They're able to get water in and out of the ear pretty naturally. It's not that big of a deal. Some of the negative aspects or the trade-offs of leaving the canal wall up are that the surgeon may unknowingly leave some cholesteatoma behind that wall. And thus, if the surgery does not work as far as removing all the cholesteatoma the first time, then more surgery might be required in the future. Some of the benefits of the canal wall down, in which the bone of the ear canal is completely taken down, is that the surgeon really gets full access to all parts of the ear during the surgery. There's sort of no wall for the cholesteatoma to hide behind. And therefore, at least theoretically, no more surgery would be needed. Additional notes to understand on a radical mastoid are that when you do a radical mastoid or a canal wall down mastoidectomy, the ear canal shape really changes, and it changes from a tube to a bowl. And so the ear canal opening gets bigger to access the bowl. It takes longer to heal this larger area. And the biggest thing long term is that the normal ear canal debris, such as earwax and dead skin, it will build up inside this bowl. It will not sort of tumble out naturally like it would out of a normal ear canal, which is shaped like a tube. And therefore, this buildup must be cleaned out in the office about every 3 to 4 months by an ENT. The other negative thing is that water getting in the ear can linger and cause infection and irritation, and for some patients they could even develop some types of vertigo or dizziness. In reality, around 20% of patients who have undergone a canal wall down surgery still have to have more ear surgery, whether it's because there's cholesteatoma under the eardrum that has to be removed, or because the mastoid space is still having issues and infections. Some of our modern techniques, we try to minimize some of the bowl shape by filling in some of the space, also known as obliterating some of the space, because we know that these large mastoid bowls can really be problematic for patients. The decision for canal wall intact versus canal wall down is often made during the surgery based on what the surgeon finds. Doing the canal wall down procedure is essentially irreversible or permanent, and therefore many surgeons will attempt to preserve the natural ear canal structure as long as possible. But if after many surgeries, if the cholesteatoma continues to come back again in the mastoid and require multiple surgeries, then the canal wall down surgery is considered and makes pretty good sense.
Again, probably the most important thing I want patients to understand from this is that cholesteatomas can come back. And it's unfortunate, but it's the fact of life right now for cholesteatomas. Recurrence rates really depend on a lot of factors, how big it is, where it is. In general, these growth rates of cholesteatomas are pretty slow. So if it's going to grow back, it's not going to grow back in a week or two or a month or two. It's usually going to be 6 to 12 months before we see the first signs. So usually we'll do a recheck for regrowth, but we'll do it something like 6 months later. The traditional way we did this for many, many decades was we just went back to the operating room and lifted up the eardrum and looked on the inside to see if the cholesteatoma had come back. Sometimes we would do that and discover that there was no cholesteatoma, which was good news, but that meant the patient went through a whole surgery for arguably, little to no benefit. So another method we have nowadays is to do an MRI scan, a very particular type of MRI scan that's fairly accurate, probably 95 or greater % accurate at detecting cholesteatomas. And so that's what we talk about. These are the different surveillance options. Surveillance meaning we gotta keep an eye on this ear and see if it tries to regrow cholesteatoma. So again, the two options for this, one is what we call a second look surgery. So the first look was the surgery to remove the cholesteatoma. The second look surgery is to go back in there, open up the ear, usually around 6 months later, and just look and see if it's grown back. The good things about this is that it's the most accurate way to check it. I would say it's 99% accurate because the surgeon goes back in there and can look at all the areas very, very well. Another good thing is that if there is cholesteatoma present, then we can just remove it right then and there. And we're already in there, so we'll just take it out. The negative things are that obviously requires going to the operating room, requires anesthesia, there's some downtime afterwards, there's some restriction afterwards. And again, if there's no cholesteatoma, then it might seem a little unnecessary to go back and do this. So the other option is an MRI scan. And the benefit of this, obviously, is that it's way less invasive than surgery. It requires much less downtime. The negative thing is that for some patients, especially some children, it may still require sedation. So it may still require some anesthesia. And it's really only important for diagnosis. It doesn't provide any treatment options. So even if we elect to do the MRI scan as opposed to going back and doing a second look surgery, if the scan shows cholesteatoma, then we have to go back to surgery to remove the cholesteatoma. A couple other limiting things about the MRI scan. One is that if a cholesteatoma is too small, Say like if it's less than 3 millimeters, the scan will often miss it. And the other thing is that not all radiology centers can offer a specific type of MRI scan necessary to accurately diagnose cholesteatoma. What are some of the worst case scenarios? Well, if the cholesteatoma goes untreated and it spreads outside of the middle ear and outside of the mastoid, it can spread to the inner ear, which is deeper inside the skull, also known as the labyrinth. This can lead to permanent severe hearing loss as well as vertigo. When that happens, we call this an inner ear fistula or a labyrinthine fistula. This requires some different surgical techniques to repair. Another bad thing is that the cholesteatoma can spread to the skull base. The skull base is the area basically between the ear and the brain. And so if it goes through the skull base, it can lead to infection of the lining of the brain. This is known as meningitis, which can be life-threatening. And sometimes it can even get through the lining and go into the brain itself, and that's called a brain abscess. These are things that can be potentially fatal. Another thing that can happen is injury to the facial nerve. The bone over the facial nerve can be eroded, and the nerve itself can be irritated, and that can result in a facial droop or a facial paralysis. To be clear, these are not common, but people do want to know, what if I like to do nothing with this? It can cause you to be deaf. It can cause potential life-threatening situations, and also could result in a paralyzed face. So it could be very, very serious. Some other common questions that I get are, hey, can this spread from one ear to the other? And the answer is no, it doesn't spread from one ear to the other. But it is possible, and I've seen it many times, where a patient can have two bad ears, and each ear can develop a cholesteatoma on its own. But it does not spread like in the blood or by transmission from one ear to the other. Other questions are, can it spread to other parts of the body? And the answer is really no. It's not going to, metastasize and go somewhere else in the body. It starts in the ear, and it'll either grow in the ear only, or potentially it'll grow to things around the ear, like the skull base and the brain. People often say, just want to double check, is there not a medicine I can take that'll make this go away? And unfortunately, the answer is no. There's not a medicine for cholesteatoma to make it go away. We do use medicines to treat infections and to treat pain, but the best treatment for cholesteatoma is surgery.
So in summary, again, these are some of the highlights of this discussion of cholesteatoma. It is a destructive growth or a skin cyst of the ear. The main problems it can cause are hearing loss, ear infections, and drainage out of the ear. It begins around the eardrum, and as we saw in many examples, it can erode the bone and invade deeper into the skull and into the mastoid bone. It is potentially life-threatening if left untreated, as things like meningitis or brain abscess are possible. The treatment for this is surgery. We discussed the different types of surgeries such as tympanoplasty and mastoidectomy. Those are all outpatient surgeries in which the patient goes home the same day. The main goals of the surgery are to obviously remove the growth and then to repair any damaged structures such as the eardrum, the bones of hearing. Obviously, as we've discussed, cholesteatomas can grow back. Therefore, long-term follow-up with an ENT specialist is required. Some patients do need multiple surgeries in their lifetime. We discuss the standard mastoidectomy as well as the canal wall down mastoidectomy as well. There is a lot of complex decision-making. As we discussed, there's many steps along the way, and the care for each patient should be personalized for their unique situation along their journey. Thank you for listening to this talk. If you have any additional questions, again, please reach out to your local ENT specialist. Thank you.